Sorry about that. So good afternoon, everyone, and welcome to another Risk Institute online session. Today, we're really lucky to have with us Elfriede talking to us about individual experiences of older adults during the COVID-19 pandemic. So Elfriede is obviously one of our students at the Risk Institute. She has an MS in gerontology, she is also a cross-faculty PhD in the Institute of Risk and Uncertainty and the Department of Psychology at the University of Liverpool. And she's an expert in geriatric nursing and has taught for many years at nursing schools in Germany. And has taught, sorry, can whoever has their mic unmuted, just mute that, please. In addition, she's experienced in publishing nursing exam books and flashcards in collaboration with Elsevier. Her research interest focuses on the psychological experiences of older adults and risk communication from a qualitative perspective. Her major research aspects are family relationships, ageism, belonging, and resilience under the aspects of the COVID-19 pandemic. So, Elfriede, if you'd like to share your slides, please, and we'll begin.
You need to enable me, Francis. Oh, let me see.
You can share your slides now.
Yeah.
Fantastic.
Can you see it? Oh.
Yeah, can see that perfectly.
Sorry. Okay. Yeah, thank you, Francis, for inviting me to talk at the Risk Institute online. I'm presenting today my findings from the research about the individual experiences of older adults during the COVID-19 pandemic with a qualitative research approach. I'm part of a psychological research consortium between University of Sheffield, Ulster, and University of Liverpool. I would like to give a brief overview to what I'm presenting today. So first of all, I would like to introduce you to the study, the COVID-19 Psychological Research Consortium, the aim of the study, the aim of my specific study, the methods I used, how the participants had been recruited, what kind of interview questions we used, and the method, how we analyzed the data, or how I analyzed the data. The findings are based on 2 submitted papers. The first is around family relationships and how they suffered during the pandemic. The second is related to ageism, which is a cross-cultural study with Colombia. I'm hoping my colleagues from Colombia are coming soon as well. And finally, I want to share the impact which the pandemic had on older adults and what future research could help or could get more insight. The Psychological Research Consortium had been established by Richard Bantle from the University of Sheffield in March 2020. There are other universities like University College of London, Royal Holloway University of London. And this study is a national representative study in the UK, and there are parallel studies as well in Republic of Ireland, Spain, Italy, Saudi Arabia, United Arab Emirates. The aim of this consortium had been to identify with a quantitative study to research knowledge about COVID-19 attitudes and behaviors in the society. They wanted to get more knowledge about the occurrence of common mental health problems like anxiety or depression. In addition, they wanted to know what the role of psychological factors like personality, memory, cognitive reasoning, and other factors are influencing or impacting their well-being. They also wanted to know the social and political attitudes people are thinking about, how this influences the public response to the pandemic, like voting behavior or political predispositions. And of course, how these change over the course of the pandemic. And all this knowledge should lead and will lead, hopefully, to inform better management for future public health crises. There are additional studies, like myself, the qualitative study, internet-based psychological tests, diaries, and young people surveys. The quantitative study had already 6 points of interviews as you can see, over a course of 1.5 years. And several papers are already published. You can see on Professor Kate Bennett's website, and as well on the website from the Research Consortium, which Francis will share afterwards, probably in the chat or later on if you're interested in. The qualitative studies are based at the University of Liverpool, where I'm belonging to. And we do have 3 different age samples: the older adults, the general adults, and pregnant women and parents with young children. The older adults have participants age 65 and over, and I'm responsible for that. We did already 2 times of interviews, and I will come in a minute to it as well. There's a general adult sample age 18 till 64, and there are 2 interview time points as well. And the pregnant woman had 2 interview time points as well, where the lead is Vicky Fallon and Leonie Jackson. My part is exploring the lived experience of older adults age 65 in the UK before and during the pandemic. And I'm glad we have international collaboration with Colombia. Why is it so important to investigate older adults' experience? Because they have been challenged during this pandemic a lot. They experienced more serious consequences with higher mortality and probably higher morbidity. They have been already denied medical treatment, as we could see in Italy and some other countries as well. They had to self-isolate, and therefore they experienced higher loneliness, physical and social. They had been isolated. They are less likely, less familiar with technologies or with new technologies. And as media and politicians and the policies around protecting older adult, fostered ageism, stigma, and stereotyping. The method, how they had been recruited in the UK, took part via a large national representative survey via Qualitative from the Psychological Research Consortium. And they contacted in March 2020, 2,025 people. Out of these, 2,287 people were aged 65 and over, and we contacted 71 people. And 33 participants agreed to take part for interviews in the first time point, as you can see on the left-hand side, between April and July 2020. The second point, we had 29 participants, which is a really good number of participants who joined again between January and April 2021. Consent had been agreed, and either electronically or verbally, or sometimes in a written form. Ethical approval had been given by the University of Sheffield and University of Liverpool. Data collection took part or had been undertaken via phone, mostly via telephone. Some participants agreed to have video conferencing, and we had 1 participant who wrote the answers. Each interview lasted 30 to 60 minutes, and it had been recorded and saved and password protected at the university's M drive. Audio files were transcribed externally, and this is my working place from home. The method we used to interview had been semi-structured, and we asked questions in chronological order. What did you do and how do you feel? And we asked prior to the pandemic, what did you do with family and friends? And during the pandemic, what has changed? And we asked what would they like to do in future. We asked also about the views about the community, what the local and central government could do for them, and what they think about the traditional and social media. We were interested in how they communicated and if it has been changed, and what kind of technology they used. And for the older adults, we asked if they felt valued as an older adult during this pandemic, and if they had experienced any discrimination. And last question had been always, what advice would they give for someone in the same situation? To analyze the data, I'm using constructive grounded theory from Chalmers. And grounded theory is a qualitative methodology which is interested to get a deeper insight into particular phenomenon or experiences. And in my case, is the pandemic experience relevant. It's an inductive process based on the data, and the findings are unique. The ontological and epistemological standing is that I'm convinced that there are multiple truths and realities about phenomena, and that society and humans construct their own reality. And this goes along with the citation from Jarmuth. She said, I assume that neither data nor theories are discovered, either as given in the data or the analysis. Rather, we are part of the world we study, data we collect, and the analysis we produce. And she would suggest that data we are finding are co-constructed, because me as a researcher and the data or the interview from the participants are working both together to find this new knowledge. The way the constructive grounded theory works is described on the right-hand picture. It starts with a research question, and this is the experience or how people experience this pandemic, sampling and recruiting, as I just described, the data collection by interviews, and then the next part is, as soon as it's transcribed, the process of coding starts. And coding means, in this term, that every interview is read, and we are looking at each line or each sentence and identify what could it mean. And for example, I've got an example at the left bottom here. And one participant said, I mean, I'll be all right as long as I could use the technology. This is very important. And I would use as a code, in this case, technology. Someone else could use another code. The next step is focus coding or categorizing. And when all interviews are coded like this, I would look into overarching themes. So what could they have in common? For example, technology could be communication, or it could be connectivity in common. So this is an iterative process through every interview. And I would always ask the question, what does it really mean? And I would follow this process, and I'm following this process till no more insight can get with this research question. And the final stage is developing a theory. My first finding is based that family relationships are in disequilibrium during the pandemic. And we discovered that pre-pandemic, people and participants were socially connected with family members, they had strong bonding, and they established a method of support, or they had established method of support where they could rely on. During the pandemic, everything broke apart, and they experienced social disconnectedness, and the method of support changed. I would like to share quotes from the participants to highlight our findings. And pre-pandemic, the social connectedness is explained by one participant when he said, we've got 4 grandchildren, 2 elder ones are coming up to 17 and 15, and they're into musical theater. They've got all the musical genes from their granny, and then we have even done shows together. So generationally, we are mixing as well with our own grandchildren in the same show, which is wonderful. And this demonstrates how close he is with his grandchildren, how connected he feels within these rehearsals. So it gives him a huge amount of value and sense of well-being. The method of support is demonstrated when one participant said, every morning I would get up at 6 to go to one of my daughter's houses to sit with her 2 children before they went to school. Then I would go back there for 3 in the afternoon for the children going back out of school and sit with them till my daughter came home. So he is important, or his role is important to support his daughter looking after the grandchildren. So this grandparenting is an important and crucial part for many older participants and older adults, because they are important to get the life going for her daughter, and the same part they have a strong connection to the children and grandchildren. During the pandemic, participants could no longer live this connectedness, and they experienced social disconnectedness. And the next quote is really important, I think. One participant said, his grandchildren, came across from a birthday and stood on the driveway. One came rushing up to me, so I said, no. She said, Granddad, I just wanted to give you a hug. And this demonstrates that they were really close to each other, but it could no longer be lived. And in addition, it tells that the physical contact was missing. So the connectedness was somehow disrupted. And the method of support changed when one participant said, my daughter-in-law is doing my shopping for me, and they are there if I need them, you know. And she did her shopping before the pandemic, everything by herself. Of a sudden, she became more dependent, and the way of support changed for her. And one part I think is really crucial, because the social connectedness and social connectivity is so important, but could no longer live as before. So coming together, meeting, having activities together or parties could no longer be lived. So participants did rely or had to rely on technology to stay connected. And one participant said, we keep in touch with them. My brother lives in. We keep in contact with them through Zoom meetings. We are using all the technology that is available. And this demonstrates that he's using everything to stay connected. Whilst another participant said, but it's not the same as face-to-face contact. With the best will in the world, I have no cameras on my computer and I won't do computer conversations, but face-to-face. And recognizing how complicated it might be for some participants who won't have access to it. I'm showing this part of technology and digital divide because all future research, especially as well as engineers or psychologists, need to acknowledge that, first of all, technology needs to be accessible for participants. Second, it needs to be affordable. And third, they have to learn how to use it. And many participants preferred phone calls rather than Zoom at the beginning. I will have a look at the second wave of interviews, how they change probably. But I think for us as researchers, it's important to know that technology is not just giving a mobile phone or looking into a computer, but they have to use it and they have to know what to do when complications occur. We developed this model to demonstrate the differences pre-pandemic on the left-hand side and during the first lockdown on the right-hand side. Pre-pandemic, the intra-generational exchange was based on methods of support which were established. So instrumental support means that they gave grandparenting support, so they looked after grandparenting, and they exchange affectionate support, so they gave and received affectionate support equally. This brought to them, or they described it as life with meaningful value and sense of well-being, and family had been in equilibrium. During the pandemic, everything had been disrupted, and this equilibrium or exchange was no longer be possible to live. So the method of support changed, and crucial part is the instrumental support. So grandparenting could no longer be lived, but they gave support whilst they stood apart. So many participants said, I won't visit my daughter-in-law, I won't visit my children because they are vulnerable, though they stood apart. We identified this as support paradox. On the other hand, they received support whilst they got their shopping done, so which hadn't been before. Affectionate support had been given and received equally as before, but they used different methods, as I just explained before. This brought the change of a meaningful and valuable life for them. So the sense of well-being was challenged. And this brought family in disequilibrium. Just to highlight the impact, to show the graph in the middle, just to illustrate. So the dependence on family member had increased, which hadn't been before. Grandparenting came to a halt. The need of support increased a lot, and the meaningful life had been challenged. And as well, the technical challenges and the digital divide need to be recognized to stay connected. The second part of our finding is based on a cross-cultural study with my colleague Maria from Colombia and her students. And I would like to share the design we had. On the right-hand side, you can see this is similar approach we had from the first findings I used. We have the same participants, interview data from April to July, and the same, so it was the same data set we used to identify the next topic. In Colombia, they had a different recruitment because there were no big study behind. They used the so-called snowball approach. And older adults, 60 and over, were recruited via social media, mouse to word, or people they knew. They asked to take part and get to be interviewed. They had a different time because it took a while to get the ethical approval. So the time between February and July 2021, and they had 32 participants, where our participant data from year before, April, July 2020. Ethical approval had been given by Universidad del Bosque. I found a few socioeconomic background data, which I think is interesting to know. First of all, population in the UK around 66 million, whilst in Colombia 49 million. The life expectancy in the UK is 81 years, in Colombia 77 years. The GDP per capita is in dollar 34,000 and in Colombia 6.7. The unemployment rate in UK is 3%, in Colombia 10%. The expenditure about education is 5.4 in UK and 4.5 in Colombia. And people living under the UN poverty line in total in UK were 12% and in Colombia 35%. Looking at the age differences, so I luckily found people living under the poverty line age 66 and over. There are 15% in the UK and 66 and 28% in Colombia. Internet access is in the UK 95% and in Colombia 62%. The healthcare is organized in UK via the National Health Service, and everyone has free access to medical treatment, medical support. Whilst in Colombia, the health system has changed a couple of years ago and is now based on insurance. And data from 2017 suggests 95% of the population are covered with this health insurance. Comparing the ICU beds per 1,000 inhabitants, in the UK 2.4, they provide 2.4, and in Colombia 1.4. Just because of curiosity, I would like to share the data from Germany. It's not written here, but they are six beds per 1,000 inhabitants. So there's a huge difference. Despite all these differences, socioeconomic differences, we found similarities in our data from the interview. And the first, what we found is that people experience benevolent and hostile ageism in both countries. The view from the Society on Aging had been homogeneous, and everyone in both countries from our participants experienced that they lost their autonomy to decide whatever they think is important for them. Here again, I would like to share the quotes from the participants, and starting with benevolent ageism. The participants from Colombia, one said, "Right now, the government has had a very important interest in the elderly to avoid high mortality. And I think that if there has been more interest than before, and it has made others think more about the older adults." And this demonstrates that, first of all, they have been recognized, and second, it should have been done before. But they appreciated that they had been recognized as important. Whilst in the UK, one participant said, "If at all, I think the government is looking after older people. If there is any discrimination, it's positive discrimination rather than anything else." Hostile ageism had also been experienced in both, And one participant from Colombia said, it was a lot of confinement and gave me a lot of monotony, boredom, and made me sick. That isolation factor seemed cruel and severe to me. And I would like to come in a minute about the background in Colombia. And one participant from the UK said, it is sad to be for their protection, but then there's often things that society does for somebody that is claimed to be for somebody else's protection. And he related this statement to previous times when people with disability were suggested to be treated separate, to be schooled in different schools, to be supported especially. And his idea had been that this is just to lock them away and not being visible in the society. And he compared the advice to shield and self-isolate, the same for the older adults. The society's view on aging is homogeneous, and in Colombia, they had been called in the media and from politicians as grandparenting or elderly. And one participant said, the president said to the grandparents that we have to lock down and don't know why it has to be mandatory. That is a lack of respect, a sovereign lack of respect for that asshole. I'm sorry for the language, but we want to be authentic with the participants. So this is that they are going against these homogeneous view. They don't see themselves as grandparents or as elderly. From UK, one participant said, in terms of a lockdown, continuing for anybody, and I really would kick out against that because I don't think I fit the bill that needs to be cocooned yet. Possibly I mentally do, I don't know, but I don't. Sorry, I have a problem. So he said he doesn't want to be cocooned yet, and he doesn't feel that he needs to be cocooned. And this was kind of an oppression that everyone in this age group needs to isolate. The third theme we identified is that one participant that so the feeling of loss of autonomy to decide what health behavior is good for them. One participant said, oh no, that you have to take care of them older adults. That is age one has more responsibility and one knows to care better than a 20-year-old kid. They annoyed me. So they felt more confident to use their common sense what to do in a health crisis, and rather than being told what to do. And one participant from the UK said, I want that freedom. I would feel that was discrimination against age if we were forced to keep the lockdown longer than other participants of the population. So he was desperately looking to get his freedom back. The differences between the UK and Colombia is important to highlight here. So first of all, the background in Colombia, the government implemented a mandatory health measure to prevent further spread. So isolation from people aged 70 above was mandatory. And first of all, it was probably for 3 months, and it had been extended till August. This brought lawyers and well-educated people to start a legal action against this law. And this legal action won, so these measures are no longer in place. But this legal action brought a lot of awareness and visibility within the society. And all of a sudden, people felt acknowledged they're existing, they are part of the society, which hadn't been before. And one difference is that they have no trust in the government, as you have seen with one of the quotes. The UK participants from the UK criticized the shielding advice from the beginning. So they hadn't been any progress of saying, oh yes, it's all right. We saw one or two with the benevolent agents, and they agreed it's okay. But many of them said they disagreed, and they were like, you know, we have to grin and bear. This kind of stoicism was in all the data, and they had mixed trust in the government. For the participants in the UK, it was difficult to go for shopping, for essential shopping, because they were no longer allowed to go for shopping. Even they did provide special shopping slots early morning, for example, and many had to go for online shopping, but this was difficult because the delivery slots were really limited. The homogeneous view in the UK persisted during this time. There were no change in the media nor in the policies. Participants from the UK felt discriminated, from Colombia, sorry, felt discriminated when they had been named elderly or grandparenting. And many participants felt valued from family, but not from the society. We developed this graphic to demonstrate how complex the ageism is established within the society. First of all, there are a lot of stereotypes, prejudice, stigma, and self-stigma from within the older adults that they need protection. Older adults had been seen as vulnerable and unable to make their own decisions. This had a huge impact into policies to stop spreading the virus, as well as into media, social media platforms, and politicians. So they had, on the left hand, older adults had been forced to stay at home, and this advertising from the media, as well as the policies to stop the virus, made older adults feel vulnerable, anxious, and depressed. So this impact older adults' well-being. They had an increased anxiety, increased depressive feelings, uncertainty, fear, and lack of control. They had limited social connectivity. This promoted isolation, as we have seen just right now, restricted autonomy. It challenged the communication because it couldn't be communicated face to face as before. They felt that they were put in one group, social, so they were kind of forced identity where they didn't feel they belonged to. They had been ignored their individual aging, and I think this is a crucial point because many years of research in gerontology have been ignored, that aging is an individual process. To summarize the impact of the pandemic on older adults. So, as I just said, limited social connectivity occurred. It promoted isolation, restricted autonomy, challenged communication, challenged emotional well-being. And as you can see on these pictures, everyone is different. And there is, just to highlight and to stress, there is no homogeneous view at all. Everyone is different. So aging is a heterogeneous process, not a state, it's a process. And I'm thankful for the pictures. They are free available for Center for Aging Better. The next step in my research is I'm analyzing the follow-up interviews, and I'm planning to write up themes about belonging and risk communication. I do have so far a few outcomes. On the bottom, there's a blog for myself on the Institute for Risk and Uncertainty about crisis fatigue. And I do have 2 papers about family relationship and ageism with a collaboration from Colombia. And I would like to thank you for your attention, especially the participants from the COVID-19 Psychological Research Consortium and the participants from Colombia. Special thanks reaches out to Maria and her students to Colombia, Professor Scott Ferson, Ademanes, Professor Rachel Williams, Professor Richard Bandel, who is the lead, and Professor Kate Bennett, who guided me through this analyzing process and helps me in my everyday research. Thanks very much. And I'm happy to answer questions. Stop sharing now.
Thank you so much, Elfriede. It was an excellent presentation, lots of insightful information around elderly people's experiences during the pandemic. So I'll just get the ball rolling before we open the floor for any questions. I was just wondering why you didn't mention anything to do with the kind of the scandal or the issues around people's experiences in care homes and there being lack of PPE. I don't know, I'm not very familiar with qualitative research. I'm only just kind of dipping my toes in my own work.
Yeah.
But did you interview people in care homes?
No, because my my recruitment was based on the national survey, representative survey. So they might have participants in care homes, but they didn't respond to our email because we have to ask, do you agree? And this might be one of the limitations. So so the participants we interviewed were able to use email addresses, otherwise they wouldn't have been in. So they were kind of technical, able to do so, and other participants are not included in this study. But it would be a good point to go ahead and see how they experience it. Yes.
Yeah, that definitely feels like a discussion point, or something that requires a little bit more further examination. Even if you've got a few interviews, I'm sure it expose some other themes that may have been neglected, because I feel like, at least from what I've read, that the reason there might have been some ageism either in favor or against elderly people was because of this whole thing happening in the care homes. A lot of in the UK, the policy and the discussions around trying to reduce the amount of casualties in elderly people because of the care home exposure.
And I think there could be add-on studies to investigate people in the care homes. The problem with the care home is, I think, is that people are in the care home for a specific reason. And this means that they might not be able to use technology. Either they won't have the cognitive ability, or they won't have the technical ability, or they won't, it's kind of tricky. So the way to investigate and to interview this participant would have been probably face-to-face. And I would have done so if the situation would have allowed to. But this was one of the limitations we are facing.
Yeah, absolutely. Just worth noting for maybe the follow-up interviews that you're planning on doing, if it's possible to go do those face-to-face things, I think it would enrich the data substantially.
Probably, yes.
I know Dominic has his hand raised. Would you like to share your question, Dominic?
Elfriede, how are you? So my question is quite a general one, and it's just more of your experience that I think I'm going to try and get out of you. So, we're trying to do this app at the moment, the GCA thing. And one of the components we're trying to build into it at the moment is figuring out how we can gather as much information from the patient as we possibly can to figure out what their experiences are, how well they've been treated, anything that we can understand about the downsides, the kind of the not objective, but the kind of subjective downsides to some of the treatments that they might have been involved in, or anything like that. And I was wondering, I mean, it's an impossibly hard question, but have you got any feeling for what are the ways you can ask questions, or what are the questions that you've asked that you've thought, oh, well, that was really effective at getting the information out that I wanted?
So first of all, you would have to have some interviews, I assume, because otherwise you won't get this deep insight into the patients or participants. And then you would have to have open questions. So my questions have been semi-structured. I've got a rough idea what I wanted to ask, and it followed the chronological order pre-pandemic, during the pandemic, and what they did in the future, or what they assumed they might do in the future. And if you ask these participants, I would assume that you ask open questions. How was your experience previously with treating your symptoms? How serious did the health provider, the health service, took your case? Where do you think could it improve? Or what is your desire? What would help you to improve your health? And we can discuss it in a different meeting as well, Dominic. I would be happy to help to do so.
Sure, brilliant. We'll definitely do that. Unfortunately, that's the answer I was expecting you were going to say, and that's the hardest thing for us to try and embed in this app. So, but I expected as much. But thank you, Elfriede.
Yeah, you're welcome.
Yeah, I definitely relate to that. I found as well sometimes just the experience of trying and then course correcting as you go is maybe one of the more effective ways to navigate which questions work and which don't.
Yeah, you can have a trial first. So you can have a trial first. You have probably 2 or 3 people who are using the health service. And then you can ask a few questions, what you would expect they answer. But the unexpected answers are the most important, the most interesting. So so that's why it could be interesting to see, would you take part in a trial first, if you have 3 or 4 participants or people who are using the health service, and then you can see what they answer from them.
And did you find that maybe starting off with kind of easier, more basic questions and then potentially building up to more open-ended questions was an effective way to build up someone's confidence in giving a more elaborate answer? So most people do that in podcasts and things like that.
Yeah, so we started, before we came to the interview, there was a whole process of ethical approval, of course, and the participants had been given information sheet. They had been given the the ethical approval, not the questionnaires, but a description what we are aiming to investigate. So they knew what, they didn't know what we asked, but they knew around the topic. So I would suggest having a trial first and then see how your answers or your questions might fit to the one you experience or you want to get out of it. And then in the email we ask, and when you start in the interview, you're greeting them, you think hello and how are you, and but how are you leads to probably more later on, because you need to follow your protocol, which is some kind of open, so you can always have some prompts. What do you mean, and what does it mean for you, or what would you have wished to, so to get a bit more out of it.
Yeah, how are you is quite a difficult question to answer in itself, right?
Yeah. So we ask rather, so how has your life been before? And can you explain what has changed, or has anything changed or not? So it depends, yeah. And sometimes it comes up with the process of talking. So you've got your script, but when you ask and people are asking or telling something which you think, oh, this could be interesting to follow up. So you ask just a prompt, what does it mean to you? What would you like to be changed, or something like this, yeah.
Okay, thank you.
You're welcome.
Has anyone else got any questions from the audience? I know Pedro left a comment saying he had to leave, but thank you for your talk. It was very insightful. Vladimir or Conal, do you have any comments?
Yeah, just one question. When you're doing the coding of the interviews, how much can the choices you make when you do the coding affect the analysis? So
you're free, because as I said, when you use the same approaches, there are many different approaches, but when you use the constructive grounded theory, you can use, because it includes you as a researcher as well. So you're open in the choice. You're open the choice what it means to you. So there's no positivity, right or wrong. This was my first concern as well when I started. Is it right or wrong what I'm doing? But it's not. This is the right thing. What comes up in your mind at the first point. You might change it later on, though it's not fixed that you will have to stick with it. If you come back in a couple of weeks and looking at the same interview, you always can say, oh, this was not what I think. This is something different because I learned something new. So you can change these codes, and they are just a guidance. It's a basic insight which gives you just one word or 2 words, which is, okay, this is around technology, or this is around family relationship, or this is about ageism, or this is about, and this is so flexible. Okay. Does this answer your question?
Well, I was thinking that if like you say, if there were 2 people analyzing the same data, they'd each come up with, like you say, equally valid interpretations according to the process. But how different could those interpretations be?
So you might read in some papers when people are coding the same data at the same time and come to conclusions. They are negotiating, they are discussing their meaning. And I think they're discussing as long as they reached a common basis? Would you say this, that you say that you agree with? And if you've got another, the collaboration work with Colombia was really interesting, because we had different participations, and we had different ideas what's in the data. But within the discussion, we found a common ground. And this is important when you write a paper or when you disseminate something. The next paper can be about something totally different with the same data.
Okay.
Yeah, does this help? Okay.
Yes, thanks.
You're welcome.
Yeah, coming back to your point about the Colombia kind of sample and the kind of characteristics of Colombia, I just wondering, do you think you felt like you got a good spread of the different types of people in Colombia? Because I know you said quite a lot of them didn't have access to internet. Were you able to get data on these people that didn't have health insurance and internet access and such like that?
So as far as I know, they investigated people who were able to answer either the phone or the email address, or someone who knows they could interview via telephone, probably, mostly. And I recognize that I haven't looked into the background data, because I think there aren't existing. They just looked at the qualitative side. But as far as Maria said, they tried to disseminate through the whole country the interviews. So they are from different regions of the country, but they might have a specific technical standard. Otherwise, they couldn't be reached. So this implies that they know how to use a telephone or an email address. Yeah,
it's worth having that demographic data, because it might skew the data slightly towards people that were more affluent or had resources to look after themselves. Yeah, and we know that COVID affected kind of people in poverty much more asymmetrically, let's say. Yeah, and I think this is one of the limitations. Yeah, you're right. And this is one of the limitations. The same for the participants in the UK. They all were able to use email addresses and using computers. Otherwise, they wouldn't, or at least a mobile phone. Otherwise, they were not in this study. And this is one of the limitations, which is important to recognize. But when you look into qualitative work, it doesn't mean it has to be generalized. It just needs to be said, okay, this is our limitation, this is our participants, they have this such and such age. For example, probably if we have demographic data behind, that's fine. If not, this is what we've got. So you won't say this is valid for the whole population. This is not working. No, so we get a deeper insight in the small sample. And for qualitative 33 and 32 is a huge sample participants. Yeah, no, absolutely. I don't mean to discredit it at all. I just think it's worth having that demographic data there. So if you wanted to replicate the results, then you'd be able to interview the same types of people, and then realize where the limitation is to be able to explore and maybe get another side when maybe face-to-face interviews and data collection is more possible. But similar issue to the care home thing, so I don't want to spend too long kind of drilling it in, No, but it's important, because it's a so when of course you can replicate the study with participants in the UK. You can have another national survey and ask participants to take part, but this is only possible when they do have access to internet. If they don't have, you have to have a different, probably the sample size would not be as huge when they don't have the access, and second, you would have to travel a lot, so this would be much more time consuming, resource intensive. Yes, absolutely. But it's important to recognize this is a limitation of this study. Yeah, this is really important. Does anyone else have any other questions for Elfriede? And if not, maybe I would like to end with one final question, which is I know this wasn't the focus of your talk or your research, but do you feel like you gleaned any information or insight into how things should be done differently in the future, whether you have any practical guidelines if there was another wave, for example, and how we could maybe help support the elderly so that they feel like they really get the best out of policy? Big question. Yeah, I know it's difficult. So first of all, we need to think about our language. Whilst I was working with the ageism topic, our language is crucial, how we
how we establish our stigmas, prejudice, and stereotypes. So older adults are part of the society, whether we like it or not. And we can't eliminate them. So this is really important that we use think about how valued older people are in our society. This is really important, that the media, the presentation, and the politicians are not looking down. So, and I think what the UK government did was that they had some older adults, they just left it on their own. And I think they should have been more valued. Because when you look at the topic of herd immunity, that so and so many people can die, and no one started a rebellion against, which was I was wondering about. And I think that kind of statement should no longer be accepted and tolerated. So this is about ageism. The second part is that if we do have a health crisis, we should have a plan B, an emergency plan in place. And this should be prepared long before, not when the health crisis starts. And for example, providing ICU beds. You probably remember the numbers, 2.4 in UK and 1.4 in Colombia. There's not very much difference. And this might be the case why we have so many similarities as well. And I think so preparing the health service would be really important, to provide more ICU beds, more equipment, of course. And I think what is important, that people should be recognized as adults, not as minor, because they can make a decision when you explain the seriousness of a disease. They know by themselves, probably by their self-stigma, by the society, many years trained. But I think this is important, that they have a feeling what is best for them, and to lock them down. And I remember one participant, she said, I'm walking every day, I'm hiking. Why can't I just go to the beach, for example? It's 10 minutes walk from it. Why can't I get out? And I think she was really desperate and had depressing feelings. And she said, why can't I just get out? It's why does it do a harm when I'm getting out of my house? Everyone else can have exercise. Why not me? And I think this kind should be more, regulation should be more diverse and more adapted to individuals' needs.
Yeah, I think that's really, really important. I think you've obviously heard some really heart-wrenching stories. I know that anecdote you were talking about, where the granddad's granddaughter came to give him a hug and he had to shout no. It's just so upsetting to hear some of the things that you probably had to go through in the interviews. But yeah, thank you so much, Elfriede.
Thanks for writing me.
Yeah, thank you so much. It was an absolute pleasure to have you. Thank you to all the attendees. Look forward to seeing what you do next. Where can people find your work again? You were saying there was the research consortium that they can go to. I didn't have the URL, but
do you have a second? Then I can share it in the chat.
Yeah,
would
absolutely.
this be helpful? But I need to search it for a second.
No problem. Because you said that was the best place to see it, right?
Yeah. So this is about the main study where we recruited our participants from.
Okay, so I'll just read it out for I'll read it out for the recording. So it's at sheffield.ac.uk. And if you search for Psychology Consortium on COVID-19 and the news and media, you'll be able to find more up-to-date research on what Elfriede Derrer-Merk is up to. And Dominic just said, thanks for the talk, Elfriede, and we'll catch up soon about listing patient outcomes.
Oh yeah, you're more than welcome.
Thank you so much, Elfriede. Have a lovely day, and I'll speak to you soon.
Yeah, thank you. Bye.
Goodbye.